The spondyloarthropathies are sort of lumped together because they are traditionally those that don't fit the mold. Autoimmune diseases, usually women. Spondyloarthropathies, usually men. They all are sort of linked with a genetic predisposition and are generally serologically negative. So this grouping of diseases are distinct, each one of them, but they share a lot of commonalities. So let's talk about those commonalities first, and then talk about how you spot each individual disease. First, there are 4 of them, and the ones we're going to talk about can be remembered by the mnemonic pair. Not because there's a pair of them, but because they begin with P, A, I, and R. P is psoriatic. A is ankylosing spondylitis, ANKSPON for short. I is for IBD related, also called enteropathic. And R is reactive. Now you may remember studying for step 1 the learning about haplotypes. All of these diseases are associated with HLA B27. But as a diagnostic step, you should not go looking for these haplotypes. Don't get an HLA B27. Most of these diseases are seronegative. And of course, nothing is that black and white in medicine, so because they're inflammatory disorders, you might have non-specific markers be elevated, like the ANA or the rheumatoid factor. But I want you to learn these diseases as having absolutely all serologies be negative, so trying to track down the source of these diseases with serologies won't work. What you can do is use plain radiographs. The X-ray is a pretty good test. Even though it may not catch very early disease, what you're looking for is bony erosions, joint destruction in the particular joints that get involved. And that's very nonspecific, I know. Advanced imaging generally is not gotten. So CT is a better X-ray, but that should only be used when you're looking for occult fractures. Way outside the realm of an M3, but we'll talk about in ankylosing spondylitis how it might be relevant. The MRI is the best test by far, but is really expensive. And since most of these are clinical diagnosis, you don't need to do it. It has to be a really, really specific case where you clearly know this person has one of these arthritises, but then they just are negative on everything else. So generally try to avoid the CT and avoid the MRI. All of these diseases are going to be men more than women, which makes them unique in the sense that it's an autoimmune disease that happens to men. You don't do a lot of imaging. There's not a lot of testing you can do. So most of the time, it's a clinical diagnosis. So when you end up with a clinical diagnosis, you're going to treat them basically the same way. NSAIDs is the backbone of therapy. And as you learn from rheumatoid arthritis and lupus, NSAIDs are not first line. In fact, they're actually harmful because all they do is control symptoms. But in spondyloarthropathies, NSAIDs come first. Local steroids can be used. Generally, systemic steroids are a bad idea, and as we've learned in this course, get people off steroids. So local glucocorticoid injections can control symptoms. DMARDs can be used with the caveat of they do not help the axial skeleton. So if they've got peripheral arthritis, they can use DMARDs, hydroxychloroquine, methotrexate. But generally, they're not going to work. And if they get severe enough, where you need to go is the TNF-alpha inhibitors, as you tried everything else and have not been able to gain control. So this is sort of all spondyloarthropathies all at once. Let's talk about each individual one at a time. And the one that gets tested the most is ankylosing spondylitis. We know it's most likely going to be a man, more so than a woman. And it's all about sacroiliitis. That is sacroilium inflammation. It's low back pain. But it's low back pain that gets better with use. That is, there's morning stiffness. It takes them more than an hour, but once they get going, their back loosens up and it hurts less. If they rest for a while, their back will hurt more. And we've encountered morning stiffness before in this course, and that was rheumatoid arthritis. But remember, rheumatoid arthritis is going to be the digits, right? small joints, fingers, and toes. Ankylosing spondylitis is primarily going to be sacroiliitis. That's the low back pain. And because there's that low back pain from the sacroiliitis, it does have a diagnostic step. And that's the x-ray. And you want to get a lateral lumbar. What you're looking for is the bamboo spine. Now, while that may be a late finding, if you find it, diagnosis is done, it's ankylosing spondylitis. The treatment is going to be with NSAIDs. And localized steroids can help with exercise because exercise, physical therapy, is going to actually improve the disease. DMARDs generally are not used for ankylosing spondylitis because they don't work for the axial skeleton, and this is all about sacroiliitis. If there also happens to be peripheral arthritis, you can use the DMARDs in that way. But where you're going to go with ankylosing spondylitis that fails to respond to NSAIDs and steroids is anti-TNF alpha. There may be, though, the time when someone comes in with back pain. In a person without ankylosing spondylitis, if someone has lower back pain after lifting a box, you don't know anything, right? It could be a hernia, could be a pulled muscle, NSAIDs and exercise. But if someone has ankylosing spondylitis and they come in with back pain after lifting a box, they need the CT to check for the occult fracture. That's what we were talking about that earlier. So very specific cases of that CT, don't learn that, just recognize that that might be a caveat. And if that comes up on your test, you won't be duped. All right, that's ankspon. Next is psoriatic. Patient's going to be a man, more than a woman, and guess what they're going to have? You guessed it, psoriasis and arthritis. Now, it is possible for the arthritis to occur before the psoriatic plaques, but on a test question, they just can't do that to you because you'd have no idea. So if the person has psoriasis and they have arthritis, that's psoriatic arthritis. If they show you a picture of a person's fingers and they've got little holes in them, like someone took a pin and sort of started drilling, nail pitting in an arthritis question, psoriatic arthritis, job is done. The diagnosis is clinical. And the treatment is basically the same thing as for ankylosing spondylitis. NSAIDs, local steroids. Here, DMARDs will work because there's usually going to be distal arthritis in the fingers, hands, and arms. And then if it doesn't work, anti-TNF alpha. Now, psoriasis can be treated with UV light and steroid creams, but the arthritis may persist. So even though you treat the psoriasis, the arthritis may not get better. Next up is reactive. And while it does not have to be an STD, I want you to learn it that way. Because again, if it's going to be an enteropathic organism, which can cause reactive arthritis, it's going to confuse you because we're going to talk about enteropathic arthritis next. Inflammatory bowel disease related is enteropathic. So what I want you to learn to keep it straight, to keep all these diseases separate from one another, is that reactive arthritis is from an STD. So the patient is going to present, because in men more than women, with urethritis. It could be a cervicitis if it was a woman, plus arthritis. If you see urethritis and arthritis, it's reactive arthritis, caused by generally non-gonococcal STDs. But if they throw in there also conjunctivitis, that's Reiter syndrome, diagnosis is done. Now, if they came in with a red, hot, swollen, tender joint, you're going to tap it. But any tap you do is going to be negative. It's not going to be in the septic range. There's not going to be organisms. It's going to look like an inflammatory joint. And if you're thinking it's an STD that they are infected right now, you need to go find the infection. It's going to be a swab. Wherever semen can go, you need to look. Throat, anus, cervix, urethra. If you find that there is an infection, that they're actually having an STD right now, you treat. And as we learned, even though it's non-gonococcal, which means it's probably chlamydia, you treat both. To treat the chlamydia, you either use doxy or azithro. There's debate right now whether they're equivocal to each other, but they can't make you choose doxy or azithro. And you treat the gonorrhea with ceftriaxone. I want to make this very clear. If they have an infection, you treat them. If all they have is the arthritis, you do not give antibiotics. They just have reactive arthritis without the urethritis or cervicitis. You can't find an STD. Don't treat it. Because the treatment for the arthritis itself is NSAIDs and time. Most of these will resolve spontaneously on their own. So only if they get infected and you find an active infection should you give antibiotics. Antibiotics are not useful unless they have an active infection, which is why you go looking. We close out with inflammatory bowel disease related. This is enteropathic. This is the only one where men are affected equally to women. And of course, they're going to have some inflammatory bowel disease. That means either Crohn's or UC, plus arthritis. Well, if they've got inflammatory bowel disease and they have arthritis, diagnosis is done, it's irritable bowel disease related. The diagnosis is clinical. But you have to be careful because ankylosing spondylitis also has a predisposition in patients who have UC. So someone could have inflammatory bowel disease and have ankylosing spondylitis. And here's the difference. If you treat inflammatory bowel disease related, and you treat the inflammatory bowel disease, the arthritis improves. And you should not give these patients NSAIDs. Should not give these patients steroids unless you're treating their inflammatory bowel disease. So if you find someone with inflammatory bowel disease and arthritis, treat the inflammatory bowel disease. Arthritis gets better, done deal. If it's low back pain and they don't get better, it's probably ankylosing spondylitis and they need to be treated. So let's go through this one more time. A pair of diseases, psoriatic, angst-spond, irritable bowel, and reactive. Don't get genetics, don't get serologies, only use very non-invasive, cheap imaging unless it's ankylosing spondylitis and you're worried about a back fracture. Men more than women, and the treatment generally goes NSAIDs, localized steroids injections, DMARDs, but not for the axial skeleton, TNF-alpha inhibitors, if all else fails. The 4 diseases you need to spot: ankylosing spondylitis, men in their 20s, low back pain with morning stiffness. Psoriatic arthritis, psoriasis and arthritis. If you see a picture of a hand with nail pitting, diagnosis is done. Reactive arthritis is urethritis, arthritis conjunctivitis. Antibiotics only if they have an active STD. And inflammatory bowel disease related, someone has Crohn's or UC and arthritis. That's the spondyloarthropathies.